And C5 palsy is one of such complications that you might have to deal with in practice. It's a well-recognized problem, and by definition, it is called a dissociated motor loss, more motor than sensory. Paresis of the deltoid with or without the biceps after a cervical decompression that typically involves the C4-5 segment without any deterioration of myelopathy. And the incidence, if you look in the literature, is all over the place. There are C5 palsies reported after anterior surgery, but to tell you the truth, I have never experienced this in my life. And I don't know any surgeon who has got a delayed C5 palsy, or even for that matter, acute C5 palsy after an anterior surgery. But posterior surgery, yes, the literature gives an incidence of anything between 0 and 24%. But I wonder what the guys who have reported 24% as incidence are doing in their surgeries, because that's absurdly high. But overall, the pooled incidence for posterior surgery in systematic reviews is about 6%. But these studies are all low-powered retrospective studies. I found that this study is a very large retrospective multi-center study. And actually, this study was criticized by the editors for having such a low C5 palsy rate of less than 1%. But this probably is more closer to the truth, and this is what I have experienced in my practice as well. But overall, the laminectomy with fusions tend to have a very high incidence of C5 palsies, and probably because I don't do that many lami with fusions, maybe my rates are lesser. Laminoplasty is the least rate of post-surgery C5 palsy. The clinical presentation is very varied. Usually it is unilateral, but I have seen one bilateral C5 palsy in my KEM days. Usually it is C5. I have also seen a delayed T1 root involvement after a posterior surgery, a laminoplasty. Usually sensory is spared, but sometimes you can get a sensory loss. Usually painless, but sometimes it can be painful. Most of the time it's a delayed presentation a few days later, but sometimes it can be an immediate onset also. And most recover, but some don't, and we'll see that. And there are many etiologies or theories for these. And the obvious one actually is a direct nerve root injury, and you are doing surgery there and using a burr, and you have injured the nerve root with either your foot plate of your Kerrison punch, and this is kind of more obvious, and usually the surgeon knows when they have done something like this. But when you don't know something, then you blame things like nerve root ischemia or reperfusion injury or something, whatever that means. Segmental spinal cord injury can happen, obviously, at that level, will cause a low motor neuron injury. Derotation of spinal cord, I don't know what this means, but there are some people who say that, the spinal cord derotates after a posterior surgery, and that may be responsible. But what is most accepted theory of a palsy, maybe immediate, maybe delayed, is the cord float theory, where the cord moves back after a posterior decompression, and you get a traction injury of the C5 nerve roots, especially if the nerve root is tethered into the foramen. And that's kind of the most common theory that people think of. But I want you guys to think of C5 palsy as not just one mechanism of injury, because the presentation is so varied, like we saw, that it's probably unlikely that you have one mechanism of injury. It probably is very different kinds of insults that a patient may have after surgery, and maybe it's a combination of things that lead to C5 palsy. But when you look at it, then why just C5? Why doesn't it happen more often in other nerve roots? And people again have thought of this, and they say that the C5 nerve root is the shortest one, it has the most horizontal course, is the smallest nerve root in cross section. The C4-5 foramen has more anteriorly protruding facets. The C4-5 is the apex of the decompression when you do a posterior surgery, and probably that area is the maximum distance when the cord floats away. And cadaver dissections have found like a lot of tight foraminal ligaments in the C4-5 foramen which tether the nerve root there. And then a kind of a deltoid has a more single nerve root innervation, so the injuries start becoming more apparent more quickly for a C5 palsy. And there are many risk factors in literature, and I found that these probably are the more significant ones, and we probably can't go over everything. But multiple papers have pinned this risk factor as one of the common ones, the foraminal diameter, and it kind of more applies to posterior surgery. I don't know how this applies to anterior surgery, because in anterior you are kind of opening the foramen anyway. But this association seems to be more dose dependent, where the odds of having a C5 palsy triple every millimeter increase in foramen foramen diameter, that is decrease. And this is also associated with sometimes either clinically C5 radiculopathies patients get, or it may be subclinical also. On EMGs you have found that patient has a C5 involvement, and those people are kind of at risk. This one, the more lordosis that the patient has and the more wider laminectomy you do, the more cord float that is going to happen, especially if there is foraminal stenosis. So it intuitively makes sense that this could happen. So your preventive measures are probably trying to limit the amount of lordosis that you put in a patient, especially when you are trying to do deformity corrections like this for post-laminectomy kyphosis, and when you are forcefully correcting something into lordosis, you have to be careful, because the foramen kind of narrows down and the pedicle comes down, and maybe even foraminectomies may not help such kind of patients. And there's this one good test that you can do, especially for patients who have kyphosis, or where you feel that the foramen is narrowed down, is a pre-op lordosis position that you give for about 10 to 15 minutes. And I learned this from Dan Rue, who kind of used to put his patients in the supine position in an extended in the clinic for 10 to 15 minutes and ask them whether they are developing any numbness or radicular symptoms. And if they do, and the plan is to do a posterior surgery, you always used to do a prophylactic foraminectomy for these patients. And I kind of started doing these in my practice. But for preventing it, I really don't know what works. And there are several people do intraoperative neuromonitoring, but see, palsies develop in a delayed fashion as well, so I don't know how that helps. Foraminectomy for every patient is absurd thing to do, because not only you will risk injury by the decompressions done for every patient, you can't really every time ensure that your surgery will not damage the nerve root. Longitudinal durotomy seems excessive thing to do, and chilled irrigation steroids is like anybody's guess. You can do what you like. I'll tell you what I do. I do counsel pre-op for risk of C5 palsy to all patients who are getting a posterior surgery, and I quote the incidence as 6%, probably higher than usual, but I like to kind of warn the patient beforehand. I document pre-op shoulder movement, examine them active as well as passive, because some of these elderly patients don't have a passive range and they have stiff shoulders, and if you don't examine them pre-op and then post-op realize, and then you don't know what is really happening to these people. And I assess the pre-operative like foramen situation, especially at C4-5, and sometimes very arthritic cervical spines. I frequently get CT scans to assess the foramen, sometimes an EMG, then the pre-op lordosis position test. And you really, after surgery, you yourself have to go and do the C5 examination in the recovery room, and not let your fellows or residents rely on that, because they may not do it properly, and a lot of your decision might depend on this. So make sure that you yourself, if you have done surgery, you're checking their C5 function. I avoid wide laminectomies. Whenever I'm doing it, I'll literally take something and I'll measure the width of my laminectomy with a ruler. I'll never go more than 18 millimeters. So it's usually between 15 and 18 millimeters. It's very difficult to judge this visually, so I'll take a ruler and measure that and make a laminectomy. I prefer laminoplasties to laminectomy with fusions. Wherever possible, I'll do a laminoplasty. Even in patients with kyphosis, up to 13 degrees, 10 degrees of kyphosis or straight spines, I would prefer a laminoplasty rather than a laminectomy with fusion, and that has worked well. And whenever you have to do a lami with fusions, do not do a very forceful correction of the lordosis. And if you have to do, then you'll have to do a prophylactic foraminectomy if you're doing a kyphosis correction, something like this. I use a steroid protocol, and it's my steroid protocol. You may have your own one. I try not to use it in patients who are on insulin. It's a 10 milligram loading dose of dexamethasone and 8 milligram dexa 8 hourly for 24 hours. I'm not sure whether it helps. No study has proven something like this. And if you have a case like this with a kyphosis and you're trying to do a posterior surgery, this patient, even if he is asymptomatic for C5 or radiculopathy, gets a prophylactic foraminotomy, because I know I'm going to do a very major correction in him. And the foraminotomy here is really like a Ponti osteotomy. You're not doing something small. You're literally tracing that C5 nerve root all the way outside. You are disconnecting that thing, seeing the whole path of the C5 nerve root before you do a correction, something like this. Because the chances of having a post-op C5 palsy in things like this is quite high. Most patients will recover. The time required for recovery is about 4 to 5 months. And the very profound deficits, the one who are grade 0 and grade 1, you need to be worried about, because they are the ones who may not recover. The grade 3s and the grade 4s usually end up recovering. No therapy has been shown to hasten the recovery. Physical therapy obviously is the critical thing that you need to do. And for treatment, you probably most of the time need to pray. And I frequently talk to a colleague, or maybe if the patient is very apprehensive, get a second opinion and all. But I look at this as two different kinds of palsies. One, you are seeing a C5 palsy happening immediately after surgery, and something that happens more in a delayed fashion. Something that happens in a very immediate post-operative period, you need to get a post-operative imaging, especially if you have done some instrumentation. Usually it is CT scan for me, because it's not really easy to interpret immediate post-op MRIs, but you may get both. And then if you find a problem with your implants, or if you have done a lordosing maneuver where you have crushed the foramen and it's apparent on the imaging, then you probably need to take the patient back and open it, especially if it's a profound deficit. But more delayed deficits, you probably can wait and watch, especially if you are grade 3 and above, because most of these delayed deficits are going to recover. But if you get a very profound deficit in a delayed fashion, which is very unlikely, you might want to image. Or over a period of time, if you realize that the deficit is not changing or improving, you might want to image and do a prophylactic foraminotomy if it is required. Having said that, I have never done a prophylactic, not a prophylactic, as a treatment foraminotomy to any patient who has developed a delayed C5 palsy till now. We'll skip the nerve transfers part, but to conclude, this is a kind of a complication of, for those people who do laminectomy with fusions very frequently, I think they would experience these complications more frequently than those who rely more on laminoplasties. But the presentation is very varied, so remember that you can have more than one mechanism of injury and not treat all C5 palsies the same way. You need to counsel them pre-op, expect it. It is very distressing for the patient not to be able to raise their shoulders. So be empathetic, be kind to the patient, don't ignore. The moment the complication happens, keep the patient closer to you. Be worried about very severe deficits, and you need to be a little aggressive with them if they don't show any change. And prophylactic foraminotomy is, for me, only for high-risk patients. Thank you very much.